All right, let's jump right in. Imagine this. A patient walks into your clinic. They've got these painful sores in their mouth that just won't heal. Now, it could be a lot of things, right? But it might just be the very first clue to a really complex systemic disease. Today, we're going to put together the puzzle of Pemphigus vulgaris, a condition where you, as future dental professionals, are literally on the front lines of detection. Let's get started. So, here's our game plan. We're going to follow the exact path you take in a real clinical situation. We'll start with what you see, the patient in your chair. Then, we'll dive deep into why it's happening, the attack from within. After that, we'll look at how to confirm it under the microscope, make sure it's not a lookalike, and finally talk about how we manage this thing. Let's do it. Okay, so let's set the scene. A patient probably in their 40s or 50s is sitting in your chair, and their main complaint? These incredibly painful sores that have been hanging around forever. At first glance, you might even think, oh, maybe just some bad canker sores. But these are different. They're persistent, they're really uncomfortable, and this right here is where your investigation truly begins. 70%. Look at that number. This is exactly why you need to know this disease inside and out. In a huge majority of cases, the very first signs of Pemphigus vulgaris don't show up on the skin. They show up right in your world, in the mouth. This puts you, the dental professional, on the absolute front line. Your sharp eyes can catch this disease before anyone else even has a chance.
You know, there's a classic saying in oral pathology for these lesions: first to show, last to go. And it perfectly captures what happens. As we just said, the oral ulcers are almost always the first sign, sometimes showing up a full year before any skin lesions pop up. And what's more, even when treatment starts and the skin clears up, those oral lesions, they're stubborn. They are almost always the very last to heal.
So what exactly are we looking for? Well, you'll see these painful ulcers, but the key thing to know is that they didn't start that way. They started as these really flimsy, fragile blisters, or bullae. They're so delicate that they pop almost immediately, leaving behind that raw, red base. Now, here's a crucial test you can do right there in the chair, the Nikolsky sign. If you take your finger and apply just a little bit of gentle pressure to the normal-looking tissue near a lesion, and that top layer of epithelium just peels away, that's a positive Nikolsky sign, and that is a huge red flag for pemphigus. Okay, so we've seen what this looks like in the clinic. Now let's go a layer deeper and figure out why it's happening. Pemphigus is, at its heart, an attack from within. It's an autoimmune disease. This means the body's own defense system gets confused and starts targeting its own healthy cells. It's literally a case of friendly fire. The one word you have to know to understand pemphigus is acantholysis. It sounds complicated, I know, but the concept is pretty simple. It's the breakdown of the connections between epithelial cells. So imagine your epithelial cells are like bricks in a wall. The mortar holding them all together are these little structures called desmosomes. Acantholysis is basically the process of that mortar dissolving, causing the whole wall to lose its integrity. The cells just fall apart from each other. So how does this ungluing actually happen? It's a very specific, targeted attack. The immune system starts producing these rogue antibodies, a type called IgG. And these antibodies have one target in their sights, a protein called desmoglein 3. This protein is a super important part of that cellular glue, the desmosomes. So when the antibody latches onto desmoglein 3, it messes up the whole junction. The cells lose their grip on each other. That's our acantholysis. And then fluid rushes into that new space, forming a blister right inside the epithelium itself. Okay, a positive Nikolsky sign gives us a really strong suspicion, but to be 100% sure, we need confirmation. We have to go under the microscope. This means taking a biopsy, and not just for a regular look. We need to use some special tests to actually light up the antibodies that are causing all the trouble. Under a regular microscope, the pathologist is going to see the direct results of that acantholysis we talked about. They'll see a split, or a cleft, happening within the epithelium. The classic sign is that the split happens right above the bottom layer of cells, the basal layer. So we call it a suprabasal bulla. That bottom layer stays attached, kind of looking like a row of tombstones. And floating around in that blister, you'll find these individual, rounded up cells that have broken loose. We call those free floaters to zinc cells. Now, to prove this is an autoimmune attack, we have to find the culprits themselves, the antibodies. We've got two main ways to do this. There's indirect immunofluorescence, or IIF, which looks for antibodies just floating around in the patient's blood. But the real gold standard is direct immunofluorescence, or DIF. With DIF, we're taking a piece of tissue and looking for the antibodies that are already stuck to the cells. We're catching them red-handed right at the scene of the crime.
And this is the smoking gun. This is what a positive DIF test looks like. Using fluorescent tags, we can light up those antibodies that are stuck between the cells. And what you get is this classic, unmistakable fishnet or chicken wire pattern. When you see this beautiful, glowing pattern around the cells, you have your definitive diagnosis. Game over. Okay, but hold on. Before we can officially stamp this as Pemphigus vulgaris, we have to be good clinical detectives. That means we have to rule out other conditions that can cause similar-looking blisters and ulcers. This step is what we call building a differential diagnosis, and it's absolutely critical. There are a few lookalikes, but one in particular stands out.
The number one condition you need to tell apart from Pemphigus vulgaris is mucous membrane pemphigoid. They sound alike, they can look alike at first, but believe me, they are fundamentally different diseases. Let's break it down. Look at the antibody target. Pemphigus attacks the desmosomes between the cells. Pemphigoid attacks the basement membrane below the cells. This means the split happens in a different place. Pemphigus is intraepithelial, within the tissue. Pemphigoid is subepithelial. The entire sheet of epithelium lives off. Clinically, this is huge. While both affect the mouth, pemphigoid often hits the eyes and can cause scarring. It can even lead to blindness. Pemphigus doesn't typically scar. So once we've nailed down the diagnosis, the final piece of the puzzle is management. And this is so important because without treatment, Pemphigus vulgaris can actually be fatal from things like fluid loss and infection. The good news is we have very effective treatments now that have completely changed the game for these patients. Traditionally, the cornerstone of treatment has always been high-dose systemic corticosteroids, like prednisone. These are powerful drugs that basically tell the immune system to stand down. But they're kind of like a sledgehammer. They work, but long-term use comes with a ton of side effects. A weakened immune system, bone loss, high blood sugar, you name it. So to help with that, doctors add what we call steroid-sparing agents to try and reduce the steroid dose as much as possible. But that sledgehammer approach feels a bit clumsy, right? You're shutting down the whole system just to stop one little part from misbehaving. Well, fortunately, treatment has gotten a lot smarter. We now have what are called biologic agents, which are therapies that can go after the problem with incredible precision. The real game changer here is a drug called rituximab. It's a monoclonal antibody, which is basically like a tiny heat-seeking missile for your immune system. It's engineered to find one specific target, a protein called CD20 that sits on your B lymphocytes. Now, why is that important? Because B lymphocytes are the little factories that are churning out all of those destructive autoantibodies. So rituximab takes out the factory, stopping the problem at its source. It's incredibly effective, and its side effect profile is so much better than being on high-dose steroids for years. So what does the future look like for our patient? Well, with these modern treatments, the prognosis has improved dramatically. The mortality rate has plummeted. But, and this is a big but, this is a chronic disease. It's not something we can cure. This means patients are likely going to need some form of low-dose maintenance therapy for life to keep the disease in remission and stop it from flaring up again. Wow, okay, we have covered a ton of ground here, from the clinic to the lab and back again. So let's bring it all back to where we started. You, with a patient in your chair. After all of this, what's the single most important thing you need to walk away with today? It really all comes down to this. Early detection is key. Remember that 70% statistic? You are the healthcare professional who is most likely to see the very first signs of this serious disease. Your vigilance, your willingness to investigate those persistent oral ulcers, that can be the absolute difference maker. A timely referral can lead to a timely diagnosis, and that can spare a patient months, maybe even a year of suffering. You can literally change the entire course of this disease for someone. Never, ever underestimate the power of a thorough oral exam. I really hope this deep dive has armed you with the knowledge you need to spot this in your own practice one day. If you want to keep exploring complex topics in oral pathology, please come find me on my YouTube channel, Master Oral Path. Thanks so much for joining me.